Welcome to Boston Community Health. I'm Dr. Elias Thorne. Today I bring a shocking truth: many cases of memory loss in seniors are not caused by natural diseases, but actually stem from your very own family medicine cabinet. Look at the story of Margaret, 68 years old. She used to be a very sharp individual, solving crossword puzzles every single morning and remembering everyone's birthday without checking a calendar. Her daughter proudly called her the human Google search engine of their household. But a devastating turning point occurred about 18 months after her physician added a new prescription to her daily routine. Her daughter called me in tears because Margaret couldn't even remember what she had eaten for breakfast, and she began getting completely lost while driving home from the grocery store she had visited for 20 years. Margaret's neurologist strongly suspected she was suffering from early-stage Alzheimer's disease. Her entire family was completely devastated by the heartbreaking news. But there is something incredibly critical that nobody ever told them, and this is exactly what I need you to listen to very carefully right now. Margaret's dementia wasn't caused by the dangerous Alzheimer's disease at all. The real culprit was hiding right inside her medicine cabinet. When we systematically reviewed all of her medications and made strategic changes under strict medical guidance, Margaret actually started coming back to us. Within just 4 short months, she was completely able to solve those crosswords again on her own. This is not a miracle story, this is the core of preventable medicine. Today, I will walk you through the 9 most common medications that are quietly destroying your memory. Before we dive deep into the list, I want to be perfectly clear about something: I am not telling you to stop your current medications. Please do not do that without speaking to your physician. But you have every single right to ask questions, to fully understand what is going into your body, and to actively advocate for your brain health. Knowledge is not dangerous, silence is. Right now, take a second to click like, subscribe to Boston Community Health, and drop a comment below telling me your age and what medications you take. We begin with medication number 9, diphenhydramine. Ask yourself how many of you currently have a bottle of Benadryl or an over-the-counter sleep aid containing this active ingredient right on your nightstand. I guess it is a huge number, and I completely understand why you do it. It is cheap, it is over-the-counter, and the package clearly states it is a sleep aid. People assume it is completely harmless. But here is what that little pink pill is actually doing inside the brain of a person over 60. The active ingredient diphenhydramine belongs to a specific drug class scientifically known as anticholinergics. This phrase is going to come up repeatedly throughout this video, so remember it carefully to protect your nervous system health. Anticholinergics work directly by blocking an incredibly vital neurotransmitter inside the human brain called acetylcholine. This is the primary chemical messenger responsible for forming new memories, maintaining maximum focus, and keeping your mind alert daily. When you are young, your brain naturally has a plentiful baseline of acetylcholine to spare. But when you have crossed the age of 60, your body is already running on a much lower baseline of acetylcholine compared to your younger years. If you block even more of this chemical messenger with a nightly Benadryl pill, the long-term impact becomes highly significant. A landmark study published in the Journal of the American Geriatric Society found that older adults using diphenhydramine regularly faced a substantially elevated risk of cognitive decline, along with measurable shrinkage in memory-related brain regions clearly identified in advanced neuroimaging studies. The sneakiest part is that this active ingredient hides in dozens of products you would never expect. Anything labeled PM, nighttime relief, or sleep formulas almost certainly contains this harmful diphenhydramine. Ask your doctor about second-generation antihistamines like loratadine or cetirizine because they don't easily cross the blood-brain barrier. Now we move to medication number 8, proton pump inhibitors, or PPIs. Please click like and subscribe right now if you want to receive more brain-protecting knowledge. This is one of the most overprescribed acid reflux medication classes globally. The problem is people take them indefinitely for years, when most PPIs were only designed to be used for 8 to 12 weeks. PPI medications actively reduce stomach acid to stop heartburn. But your stomach acid also serves a critical biological function: it extracts and absorbs essential vitamin B12 from the food you consume. Vitamin B12 is not an optional nutrient, it is absolutely essential for cellular brain health. A severe deficiency in B12 is clinically linked to direct memory impairment, severe depression, permanent nerve damage, and a distinct pattern of cognitive decline that mirrors early Alzheimer's disease so closely. A massive study published in the prestigious medical journal JAMA Neurology examining over 73,000 older adults found that long-term PPI users faced a 44% higher risk of developing dementia. But modern medical research has revealed an even more terrifying layer: PPIs may accelerate the biological accumulation of amyloid beta plaques. This is the toxic protein buildup that blocks synapses and stands as one of the defining features of destructive Alzheimer's disease. We are no longer just discussing a simple dietary nutrient deficiency story, we are potentially talking about a direct molecular pathway leading your body to permanent central neurodegeneration over time. What should you do instead? Talk to your physician about slowly tapering off PPIs using safer H2 blockers like famotidine as a temporary medical bridge. Small dietary modifications such as eating smaller meals, avoiding late-night eating close to bedtime, and elevating the head of your bed slightly can dramatically reduce your acid reflux symptoms naturally. If you must stay on PPIs long-term for genuine medical need, make sure your blood B12 and magnesium levels are tested regularly. Medication number 7 is overactive bladder control medicine, most commonly oxybutynin. Frequent nighttime urination is deeply embarrassing and disrupts your sleep, so when a doctor hands you a prescription, you take it immediately without hesitation. However, oxybutynin is one of the most potent anticholinergic medications in common clinical use. It easily crosses the blood-brain barrier and directly attacks your cognitive systems. If you find this video helpful for your family, please take a second to click like, subscribe to Boston Community Health, and leave a comment below sharing your medication experience. Your interaction helps the algorithm spread this life-saving information to more seniors. Advanced neuroimaging studies have demonstrated a terrifying reality: the hippocampus, the brain's critical memory filing and processing center, actually shows measurable volume reduction in long-term anticholinergic users. We are not just talking about temporary foggy thinking, confusion, or momentary forgetfulness. We are talking about a physical structural change, a real loss of brain tissue occurring day by day that cannot be seen by the naked eye. A comprehensive 2019 study published in the British Medical Journal confirmed that seniors using strong anticholinergics like oxybutynin for over 1 year faced a 49% higher risk of a dementia diagnosis. Early cognitive symptoms like forgetting appointments, misplacing keys, or losing words mid-sentence are almost universally chalked up to just normal aging. The bladder medication never gets questioned. The good news is that modern medicine now has a newer class of medication like mirabegron. This drug works through an entirely different mechanism called beta-3 adrenergic agonism, controlling the bladder effectively while carrying dramatically less cognitive risk for brain cells. Medication number June is benzodiazepines, commonly referred to as benzos. These are medications used to manage severe chronic anxiety, panic attacks, and long-term sleep disorders. For many individuals, this pill felt like a true lifeline during the most difficult psychological crises of their lives. I am not dismissing its short-term clinical value at all. But what I must ask you to do right now is listen to the precise scientific data regarding what happens when this mechanism stays turned on long-term. Benzos work directly by strongly amplifying a brain chemical called GABA, your body's natural calm-down signal. However, a study tracking seniors over a 6-year period found that using them for over 3 months increased Alzheimer's risk by 51%. When GABA is chronically overamplified artificially, the human brain responds by systematically reducing its own natural neural activity. Neuroplasticity, the brain's vital capacity to form new connections, learn, and dynamically adapt, begins to deteriorate severely. Memory encoding slows down drastically and emotional regulation falters. The most dangerous trap is that when you attempt to stop, the withdrawal syndrome is brutal, with rebound anxiety and insomnia becoming far worse than the original symptoms. An extremely vital medical warning: you must absolutely never stop taking benzodiazepines abruptly on your own. Doing this is medically dangerous and can cause severe seizures or central nervous system shock. You must work closely with a qualified physician on a very slow, strictly supervised tapering schedule over weeks or months. Safe clinical alternatives include cognitive behavioral therapy for insomnia, alongside low-dose melatonin or organic magnesium glycinate. Medication number 5 is the statin class for lowering cholesterol. Before explaining, I must state clearly, statins genuinely save lives from cardiovascular emergencies. But there is a hidden corner of brain architecture doctors rarely mention. Cardiovascular disease remains the leading killer of individuals over 60, and statins are highly important for that purpose. However, your brain is physically composed of nearly 60% fat. In the neurological environment, cholesterol is not the terrifying villain it has been portrayed as within the cardiovascular context. Cholesterol is an absolute structural necessity. It directly forms the myelin sheath, the critical insulating layer wrapped around your nerve fibers that allows electrical signals to travel quickly. Cholesterol is also involved directly in the biological formation of new synapses. Without adequate cholesterol, your neurons will struggle to communicate with each other. When you aggressively lower systemic cholesterol with high-dose statins, you risk crossing a critical threshold where the brain lacks what it needs to maintain its architecture. The FDA actually updated statin prescription labeling in 2012 to include explicit warnings about memory loss, brain fog, and temporary confusion. A 2023 analysis in Frontiers in Aging Neuroscience demonstrated that seniors over 70 using high-dose statins for 3 consecutive years showed a measurable increase in mild cognitive impairment compared to non-users. A highly important medical nuance to understand: not all statin medications carry equal cognitive risk. Lipophilic statins, such as simvastatin or atorvastatin, possess the chemical capacity to cross the blood-brain barrier easily and deplete the brain's internal cholesterol. In sharp contrast, hydrophilic statins, like pravastatin or rosuvastatin, have consistently shown significantly less negative impact on cognitive functions in comparative clinical studies. If you are currently taking a statin and experiencing severe brain fog or memory issues, ask your physician whether switching to a hydrophilic statin might provide cardiovascular protection with less cognitive impact. Additionally, make sure to have your systemic CoQ10 levels checked. Statin drugs severely deplete this natural compound, which is completely critical for generating cellular energy within your brain tissue to function. Medication number 4 is amitriptyline. This pill always surprises older patients because it is routinely prescribed for medical conditions completely unrelated to psychiatry, such as chronic nerve pain, migraines, or insomnia. This is an old tricyclic antidepressant developed decades ago, but it has been repurposed over time for a broad range of clinical conditions. Physicians sometimes deliberately choose it because it causes strong sedation, utilizing this side effect to help patients sleep. But what makes amitriptyline uniquely toxic and dangerous for an aging brain is its binding affinity for muscarinic receptors, the exact sites where acetylcholine performs its work, which is extremely high, higher than many bladder medications. A landmark 10-year study published in the prestigious journal JAMA Internal Medicine examining over 3,400 older adults aged 65 and older delivered a shocking conclusion: high cumulative exposure to strong anticholinergic medications, with amitriptyline being among the top contributors, was directly associated with a 54% greater risk of dementia diagnosis. What I find most troubling is the complete invisibility of this neurological damage. There is rarely a sudden dramatic warning sign. There is just a slow, creeping erosion making it difficult to find words, or hold complex logic. These warning signs are almost universally attributed to normal biological aging for years before anyone ever thinks to evaluate the medication history. Safe medical alternatives for nerve pain today include duloxetine or gabapentin, as they carry far less anticholinergic burden for brain cells. For sleep, a very low-dose doxepin has a much more favorable receptor profile, while for mood disorders, modern SSRIs like sertraline provide a significantly higher safety standard. We move on to medication number 3, a category that demands your closest attention because what I am about to reveal happens every single day in nursing homes and hospitals across this country. These are antipsychotic medications, such as quetiapine or risperidone. They were originally developed for serious psychiatric conditions like schizophrenia or bipolar disorder with psychosis. They are powerful, brain-altering drugs with a highly significant and heavy side effect profile for the central nervous system. Sadly, today they are routinely prescribed off-label to elderly patients who are simply confused, restless, agitated, or difficult to manage. This means they are being sedated not for their medical benefit, but for the convenience of short-staffed caregiving environments. The US FDA issued its most severe black box warning about this practice because these drugs directly increase the risk of mortality in elderly patients with dementia-related behaviors. Neurologically, antipsychotics work primarily by suppressing dopamine, the crucial brain chemical linked to motivation, reward, physical movement, and executive function. When dopamine is chronically suppressed over a long period in an aging brain, the clinical results include flattened emotions, slowed logical thinking, impaired memory consolidation, and accelerated neurodegeneration. A massive 2022 study published in the prestigious medical journal The Lancet Healthy Longevity tracking more than 25,000 older adults confirmed a shocking fact: seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within just 12 months, even if they had no prior dementia diagnosis. If you have a loved one in a facility taking quetiapine, ask the physician direct questions about why they are on it and what the exact plan is to stop. Medication number 2 is paroxetine, sold under the brand name Paxil. This is an antidepressant classified as a modern SSRI, a family generally considered safer than older drugs. But paroxetine stands out as a highly dangerous exception for seniors. Unlike its safe structural siblings like Zoloft or Lexapro, paroxetine possesses a highly sneaky pharmacological trait: significant anticholinergic activity. A comprehensive 2021 review in Frontiers in Psychiatry demonstrated that elderly patients on Paxil showed measurable declines in short-term memory and verbal recall within the very first year. The American Geriatric Society has placed paroxetine on their official Beers criteria list of medications considered potentially inappropriate and highly harmful for older adults. We have finally made it to number 1, the absolute ultimate danger: anticholinergic polypharmacy. As I warned you at the beginning of this video, number 1 isn't a single medication name at all. It is a completely invisible trap operating within real-world medicine. Every single medication on this list, when taken alone, might cause only very mild and barely noticeable cognitive effects in some individuals, a little more brain fog or forgetfulness that you easily dismiss and blame on your age. But in the real world, the average American over 65 takes 4 to 10 prescription medications daily, often prescribed by multiple different doctors. When several of these drugs carry anticholinergic properties, their cognitive damage doesn't just add up, it multiplies exponentially. A massive analysis in the journal Age and Aging tracking over 280,000 older adults proved that those with the highest cumulative anticholinergic burden faced a 120% increased risk of developing full dementia. Double the normal risk just from pills you consume daily. Imagine a real-world senior like Dorothy. She takes Benadryl to sleep, oxybutynin for her bladder, amitriptyline for her leg nerve pain, and an over-the-counter heartburn pill every morning. Each single pill, according to her separate specialists, is safe. But combined together, they create a toxic burden destroying her brain cells, and not a single doctor performed the math on her behalf. The medical term for this is anticholinergic polypharmacy, and it stands as the single most underreported driver of dementia-like symptoms today. But hear me very clearly on this: drug-induced cognitive decline is highly reversible. When the medication burden is systematically identified and reduced under proper medical supervision, many patients experience a remarkable recovery of mental clarity, and the fog completely lifts. Your brain is highly resilient and completely capable of healing when given the right clean conditions. Here is your concrete 5-step action plan to start taking charge this week. Step 1. Write down every single thing you take, from prescriptions to over-the-counter nighttime aids. Step 2. Look up each item on the official Anticholinergic Cognitive Burden Scale, known as the ACB scale, a free online tool to view their toxic risk scores. Step 3. Schedule a formal medication review with your primary care physician. Use this exact phrase: "I would like to schedule a medication review to assess my cumulative anticholinergic burden." A good and responsible physician will never be offended by this request. They will deeply appreciate your self-advocacy. Step 4. Ask your doctor directly about the official process of deprescribing. This is a legitimate medical term in a rapidly growing field of geriatric medicine, dedicated to the intentional, supervised process of tapering off or eliminating medications that are no longer necessary or carry unacceptable risk. Step 5. If your physician is completely dismissive, get a second opinion from a specialized geriatric pharmacist. You are not being difficult, you are being responsible about your own life. I am Dr. Elias Thorne from Boston Community Health. Your brain and intellect are priceless assets that deserve to be protected at all costs. Always stay sharp, stay highly informed, and actively advocate for your own brain wellness journey. See you in the upcoming video from Boston Community Health. Do not forget to click like, subscribe, and leave a comment below about your medication concerns right now. Your share could save someone's memory. Wishing you continuous health and a sharp mind.